going to get activated, followed by what is going to happen. There is high possibility for your procoagulant system to get activated, and there is high possibility for the patient to go for saponification at that point of time. The fatty acid with calcium is going to get react and hypocalcemia to take on. And once the patient is going for elastase activation, so capillary leak will be there. That's like a dengue-like presentation, hemorrhage, hypovolemic shock, and lysolecithinase will be predisposing to necrotic changes. And these are all the various inflammatory cascade we should not forget. The stage 1 is nothing but your pancreatic injury, followed by your local effects, by your intraperitoneal edema as well as ileus is going to take on, followed by the stage 3, the patient is going for systemic complications like organ dysfunction, SARS and other complications, metabolic disturbances, sepsis, organ failure. Once the patient is going to land up with evidence of organ failure, one of the most complex scenarios, the patient may deserve intensive care. The mortality rate is going to be high. The complications is going to take on with high things. So even with this kind of scenario, how far you're going to get intervened in order to bring the patient from shock and other things as the inflammatory cascade. So you should be very, very cautious in order to prevent this kind of complications as the day progresses. So grading your severity as per your Atlanta. So if you're going to look into this, the revised Atlanta being taken on by 2013, what they may mention as mild severe acute pancreatitis. So what do you mean by that? So mild acute means there is no organ failure, no local complications. What is the local complications? Evidence of cystic changes, wall of changes, and evidence of any abscess and other collections. So in order to prevent the local complications, and moderately severe acute pancreatitis, which means the local complications is there, and organ failure which is going to be short lasting, less than 48 hours. But once the organ failure which is going to be more than 48 hours, that nothing but a severe acute pancreatitis is going to take on. So various phases, early phase as well as late phase, the cytokine cascade is going to set in with your SARS, and late phase is only based upon occurs if the SARS is going to persist and the patient is going to have evidence of severe septic focus, followed by the patient is going to have evidence of local or systemic complications. At that point of junction, the patient is going for late phase of presentation. So this is what the Atlanta's criteria. In order to assess any patient with evidence of pancreatitis, clinical assessment. So what is that clinical given? So the pancreatitis means the pancreas, the acronym stands for. This is the basic outline. You need to give a prompt pain relief, admit the patient, and make sure the oxygenation has to be done promptly, and CVP line if the patient is going to be in shock, and radiology, hydration, rehydration. Suppose the patient is on MODs and other complications, ARDS and other complications, intubate the patient, and sometimes with your PPIs and antacids, some mechanism, and once the patient, the shock is not going to get reversed, Langerhans catheter and other things. So this is the basic acronym we should not forget, but not much in use nowadays because we are having various other protocols there, but basics will not change. We should not forget this. But assessing the parameters by your urine output, your vitals, your CVP, your baseline, as well as your hemoglobin as your BCV assessment, along with serial ABGs, all those things is important. The first and foremost thing, as you all know, that it is going to dehydrate, it's going to drink you like a fish, so you need to hydrate the patient well. So hydration is very, very important. Early aggressive hydration is important, but now this guidelines has been slightly as it reversed. Not much of early aggressive based upon the clinical picture, the presentation, the shock, the hemodynamics, the CVP factors, all those things has to be taken into account when you're going to manage a patient with severe acute pancreatitis. So hydration, the predominant solution is going to be a ringer lactate rather than going for a normal saline, because so we need normal saline if you're going to give in large may lead to non-anion gap hypochloremic metabolic acidosis. So in order to prevent that, the ringer lactate is always be a better and more pH balanced. So some textbooks given 250 to 500, some guidelines want around 200 to 400 ml per hour of isotonic crystalloids. Either you can use crystalloids or colloids. Among crystalloids, the predominant fluid is recommended as ringer lactate, and next to that it is saline. So oral is more safe and safe recommendations. If you're going to look into the paper by Ranson et al., how much of fluid loss has been there, you need to assess. And mild means it be around 3.7 liters and in 48 hours, and severe means it be around 5.6 liters in 48 hours. So there are various papers. The predictors are based upon your age, based upon alcohol as a comorbidity, based upon based upon your septicemia, SARS. So the fluid therapy, aggressive hydration